Get started. I'll get started with the roll call. Commissioner Moore. Chief Deputy Blake, I think.
I'm here for him. Yes, ma'am.
Pat Freeman. She indicated she would be joining remotely, listening in online. Sylvia Clement. I think at the last meeting, we shared that Danny Cohen is no longer the chief magistrate. And so we're waiting on notification from the current chief magistrate. My understanding is that is Matthew Moss. So until the time that he responds, and hopefully he'll be with us in June, that seat is vacant. Judge Thornburg. Todd Williams. Sam Sneed.
I'm Carrie Glassell-Grant from the Public Defender's Office covering for Sam today. He had to go to Charlotte for the Odyssey
Yes.
impending June issues. So I'm here for him today.
Thank you. Glad to have you. Tiffany Hanacho.
Present.
Donna Rose.
Present.
Chief Lamb.
Chief Lamb's out of town this week. Captain Sean Ardway.
Okay, thank you. Glad to have you with us today.
Thank you for having us. And also Lieutenant James Boyce from APD's here along with me.
Welcome, welcome. Julia Horrocks. Rachel Sawyer. Deborah Campbell. Maggie Ullman. Lori Anderson. Jay Hackett. Dustin Dow. Julie Reisdorf.
Yes.
Jean Marie is also at the Odyssey training, so she's out today. Judge Keppel.
Here.
And Stoney Blevins. Welcome, Stoney. This is your first JRAC meeting. We're glad to have you. Do a count right quick. Do we have a quorum? Not quite. With one more, we need one more. So, so until we get a quorum, hopefully we'll have another person show up. We will not move for the consent agenda to be approved. I think what we can do, the official approval is the minutes. If you all can take a look at the agenda. Are there any concerns with the agenda? All right, seeing none, and we will go back and approve it officially once we get a quorum. But we can go ahead and get started with our justice system data report. We have a jail review team follow-up. You all may recall that we did do a rather deep dive into the data from the jail review team at our last JRAC meeting. And so Lee is gonna provide us with follow-up.
Okay. Hi, everyone. I'm Lee Creighton with Strategy and Innovation. And today's, my presentation is a little bit different than it has been in the past. It's really more about an opportunity that we have to move forward with a request to the School of Government and the Criminal Justice Innovations Lab for some data that might help us understand a little bit more about some of the things that we've been discussing and some of the questions that often come up around case processing in our criminal justice system. And so as DK mentioned, this really stems from some of the conversations that occurred here at JRAC and following about the jail review team analysis. And as you all might recall, we discussed last time that yes, we are seeing impacts that the jail review team is having on reducing the length of stay for people who are in custody and specifically on the cases that they are handling. But what we're not seeing those same impacts for all groups, and specifically, we are not seeing the same impact for people of color, and specifically Black people whose cases are being looked at by the jail review team. And so from there came some conversations that the jail review team, as well as some conversations with Justice Services staff to talk about, well, what are some maybe opportunities to understand more? And what came from that is, that back to the fact of, we don't have a really good local understanding of case processing and the data behind case processing. And so that's where we have turned to the School of Government to see about possibly pursuing a request for data and analysis from them. So let's move to the next slide if you would, Josh. So before we kind of get into the details, I just want to kind of situate this, in the bylaws and the strategic plan for JRAC. And as the advisory kind of group for the local criminal justice system, you all have a strategic plan that aligns to this request from at least my perspective for two of the goals listed in that strategic plan. One being improving the racial equity within the justice system, and two being to utilize data to help enhance and inform decision-making. So with that in mind, let's talk a little bit about that first point, and specifically the racial disparity that we see in the jail population. This should not be news to folks who have been in this room and heard presentations over the last several years from me. Over the last several years, we've seen the racial disparity, the rate of disparity in our jail population increase. What we know about the jail population is there's two factors that impact it: the number of people or entries coming into the jail and how long they stay. So this first slide is really looking at the entries. And so overall, entries have remained below pre-pandemic levels for the last several years. You can see the big drop in 2020, but that top line is where you see the drop happening. And these are bookings where the top charge is a misdemeanor. That bottom line is entries where the top charge is a felony. And that's really remained pretty flat over time. This is the last 8 years. There's been some variation. We saw a little uptick going into 2019, but really the last several years have been pretty flat in terms of the number of entries into the facility. What's also been pretty steady is that 28% of felony bookings are Black people. And so, 20% of overall bookings into the jail are Black people. So there's overrepresentation there, right, in terms of our community, but it's even greater when the top charge is a felony. Let's go to the next slide. So this is the average daily population for the state pretrial and sentence population specifically. So here is where you start to see that even though our bookings are down pre-pandemic, we returned to the level that we were before the pandemic. So we're back up to previous population levels. What has changed in that is that the number of Black people in custody on average on any given day is higher than it was before the pandemic. And that then translates to a higher rate of disparity. So back before the pandemic, it was generally 22 to 25% of the local population was Black. Now it's closer to 30 to 33% on any given day. So again, bookings are still down, and so what we have is a driver of a length of stay. And our local data, go ahead, Julia.
Great. Would you mind reminding me of the percentage in the community?
For Buncombe County?
Yeah.
6%.
6, okay, I'm sorry.
So our local data, however, does not really help us understand case processing. And you all ask questions of me a lot of times about that, and I have to say, I'm sorry, I don't have that information to be able to answer that question. So just circling back real quickly to the jail review team and sort of where this has started, if you would go to the next slide for me, Josh. The jail review team has been in operation for a number of years now, and they've really honed in on areas that they can make impact. And that specifically is looking at low-level felonies and misdemeanors. And excluded from their case review are any type of violent Victims' Rights Act charges. Okay. What we learned from the jail review team analysis is, though, that because of those parameters, their caseload, Black people are underrepresented on their caseload, right? Their caseload is about 17% Black, whereas again, the population in custody is about 30% Black. right? So even though they are making an impact, right, that we talked about here with the length of stay going down for the first time in a number of years, their focus is going to make it very difficult to actually make an impact on the racial disparity in the jail population. So then the question becomes, what are the other opportunities or ways to enhance case processing that would help to reduce the racial disparity in the jail population? And that's where a request to the School of Government and Criminal Justice Innovation Lab came in to become an idea. And some of you all might be familiar with the Innovation Lab's Measuring Justice dashboard. It was put out several years back. They've been adding to it, and most recently, they've added a docket management section, and included in that are duration of dispositions. And so what we would envision here is, building off of what they've made available, ask for additional information, additional data, additional analysis for Buncombe County to include demographic characteristics. And we have been in contact with the School of Government Innovations Lab, and they are willing to receive a request from us. And the feedback that we have gotten is that it would be strongest if it would come from this body representing the system as a whole. And so, before we talk about this slide, we just want to pause to see if there's any questions about sort of the ask here and what we're talking about, or anything that I've presented so far. Okay. So we presented this possibility to the executive committee last month. From there, we've had some discussion. So I've talked to members of and heard from members of the executive committee as well as the case processing work group. And from here, I've kind of put together some proposed research questions that we might present to the School of Government Innovations Lab. And it's really focused on breaking down an understanding of disposition duration for different types of felony cases. In their dashboard, they break it down violent and nonviolent. But we would also want to look at it by demographic characteristics. We would want to kind of ask questions about what are the factors that influence or are correlated to disposition duration. So things like offense type, number of charges, prior history. How do those impact a disposition duration by race? What about sentencing, and what percentage of people with cases that are disposed are sentenced to the Department of Corrections? We've also talked about the average length of time between key points in a case, in case processing. So how long is it taking for discovery and indictment? Another thing that we've talked about is competency and how that can play a role in how long it might take a case to be processed. So this is kind of a list of things that have been brainstormed already. And so I think the ask here today is, would JRAC support moving forward with a request such as this? And if so, we could talk about the logistics of how to make that happen. But wanted to bring that to you all today to see about the support for such an ask, and if JRAC would be willing to be the body that submits the request to the School of Government. Any questions? Yeah.
I just have one in terms of the demographic characteristics. Is there any reason that we are not looking at income?
That's a good question. I don't know that they have that information in the data set.
All right.
For those court partners in the room and who work with ACES on a regular basis, is that something that is included typically?
The only place I can think that it would be included is an affidavit before the court to look at whether they're eligible for a public defender, but I don't think there's anywhere where they put their actual income.
But that might be something like a factor to consider. We've got representation type here, but is there, yeah, go ahead.
You got input from court partners
At case processing work group?
whether Do you remember anything that they brought forth, or are they giving proposed research? These were their
Yeah,
proposals?
yeah, this is what we've kind of put together after hearing from multiple places. I do think there's still probably some conversation that would be worth having with some of the offices who might not have been present at case processing before we finalize this list.
It seems like when we had our meeting, we talked about there are a lot of static factors and variables that we can look at when we're looking at jail population, and those static factors are like criminal history, actual charges and violent history. Those can't be changed. Those are static. They just can't be changed. But what the lab can help us with is these dynamic factors. Like we're not sure of what the income are. There are other factors that constantly change that we can't measure, but they can using AOC's numbers and other polls and surveys.
Are we looking at, I don't wanna say court factors, but I guess that's representation type, right? I know there've been like court studies about like how many public defenders there are and how many like district attorneys and the understaffing and like it, because we're talking about case process, especially for those higher level felonies. Like this is good on the defendant side, but I think we talk about like system moving of disparities. If we're seeing like shortages in staffing and inabilities to like move cases forward or get discovery. So I guess the question is there any like research questions around like the resources of the system to help move some of these cases forward? I don't know if that's the lab or something we would have to do.
That might be some, I know that there's been some staffing studies, I'm looking at the public defender's office. Because I know that there's recently been some staffing studies for the courts.
There was, I think, both with the DA's office and our office, and I think we were really understaffed. I think that they said we should get double. We're not gonna get double, but in DA's office, I think as well.
I do wonder though, I don't know the contents of that, but maybe it's something that if we get some data by year, there's opportunities to look at, okay, for this time period in the public defender DA's office, these were the amount of resources. Here's what we saw in the court system. I don't know that it's gonna be in ACEs in this data set that the innovation lab has, but
And sometimes those resources are legislated. Is it legislative for you? Because it is for the DA's office and like judges. Is it legislative for you
It
as
is a
well?
little bit with IDS as well.
So you can get statistics from IDS for them. But other than that, it's a legislative decision based on population as to how many clerks, DAs, public defenders, and judges that we get.
I think that would be important for if the lab can do that, name in the study to say like has the number of cases coming through increased or like the length of disposition. I think the partners have to be willing to give information. We know APD's been down staff. There are like levels of like experience in the office. My thing is I just don't think it's like the defendant's case type that's also causing. I think we're down resources, if that makes sense.
And I think also, I came from Washington State, there's a lot of movement now to redo caseload standards based on technology. Like, we didn't have body cam 20 years ago, so now you may have a case that looks fairly simple, but you have to watch hours of body cam. So you can't say a case takes less time to
Yeah, that's.
do, so that's just
I think that's what
Right.
stuff should be
case
gained.
like case complexity or something.
with the increase in technology, you have a lot more than just reading a 5-page police report on what happened. You have to watch, and sometimes it's 5 officers and they each have different body cams. And you may need to watch the one that was interacting with the witness, the client. But
I think like naming those, I guess they're variables, system variables
Sure.
would also help.
Yeah, I mean, I think, I honestly don't know all the data that they have, right? I think we should ask the question if we have it, and if they have to come back to us and say, we can't answer that, or we can't answer it how you've asked it here, here's what we could, and maybe we could have some conversation with them.
Yeah, like I'm thinking if this is a university they're able to answer research questions from their data, but if people are willing to like do interviews to see things like those are valuables, like how much body cam are you watching compared to 5 years ago? Like to ask us questions as well to help localize the data. I don't know if they have the ability to do that or not.
Did you say, have they done something like this for any other county in North Carolina?
Not that I'm aware of. At least with, Jamie Vasky, who some of you all may know, who's at Western, she's kind of been my point of contact. And I know that she's been involved in developing some of these measures that are in the dashboard. She didn't indicate that they had done these. I know that the School of Government Innovations Lab has done some specific studies. The one that comes to mind most quickly to me is one on failure to appears. So they've definitely worked with jurisdictions across the state on some specific issues. Whether they've done something.
Yeah, I'm sure this is in, you may have already went through this, but the jail health plan, I'm assuming, captures a lot of mental health, substance abuse, physical health diagnosis as part of their evaluations. Are you looking at that at all to see that some of our more traumatized populations show up in our mental health, substance abuse utilization, as well as a lot of physical health symptomatology? Is that being pulled into that to really see, are we seeing a significant increase in one of those areas or another, right? Like, what's driving some of that? Like, okay, we're seeing people potentially coming in that are, I don't know, I would say opioids, but that may be a driver in that, or it may be, lower IQs. I mean, like, are we seeing to where we actually break that down and see that there's actually fluctuations within the different categories?
So in the data that I have access to, there's not a really good way to measure that. The one place though that maybe we could talk with the sheriff's office about is their medical contractor, and is there some trend data that could be provided from them to understand population from the standpoint of behavioral health.
Yeah, I mean, we know two things. One, that population's dealing with significantly more trauma, and we know that they're less, they access medical and behavioral health services on a much smaller basis, right? So you got a population that has significant more concerns, but not getting the support they need to address them, right? So it only seems logical that those numbers are going to keep going up unless you do something about that, right? The trauma's not going away. They're not accessing the supports they need to address that trauma. And so they're going to come out, across the system.
I can certainly circle back and see if what's available through that medical provider.
Any more questions or thoughts for Lee? Lee, is there a mechanism of official request that they're requesting?
Yes, so the way that they want this to come through is through their project manager for the Measuring Justice Dashboard. And so I think you give me direction, but my thought would be we write up an official request, take it to exec committee, whether it goes directly from there or whether it needs to come back here. That would make sense.
Okay. All right.
And I can send it to.
But they would want, the request would come through me or you okay, on behalf of the JRAC. Okay, that's what I'm trying to. So if you could, based on the input that you got here today, if you could revise, finalize what our proposed research questions would be, and then we can take it back through the steering committee.
Okay.
And then send out to the body to see if people
There's
have,
feedback.
if we have support or any additional feedback.
Sounds
Does
good.
that sound okay to you all? All right.
And thanks for doing this. I think this is gonna be valuable information for our community, so good work.
Thanks, y'all.
Thank you, Lee. All right, so up next, Missy Hanacho.
We were slated to vote on the bylaw changes. We don't I have a quorum, we're missing one person. I don't know if we want to defer to June. I mean,
So there wasn't any significant feedback or additional changes that came through on the last go round. The only thing that I think was kind of in question the last time we discussed the bylaws was the number of departments represented. So we did have a discussion about that, and we've removed strategic partnerships from the current red line. We had originally removed justice services. So those two departments are removed. The other thing that has happened since then is of course, we always send our stuff to legal to take a look at it before it comes back. And so they made some cosmetic language type changes. And so please take a look at that. The final thing is I did reach out to the chamber, and I reached out to the current chair of what is called the HIAC now, just to check their temperature, let them know why this is being proposed and see if there are any concerns. Kit absolutely said she thought it was a great idea and had already thought about who she would appoint if this gets approved from the chamber. And then I talked to David Nash, who is the current chair, but the HIAC is going through some sort of a transformation. They expect to appoint their new Continuum of Care board at the end of this month. I also talked to the county's liaison about just to check the temperature. And they believe that the current members will be in favor of this, but would advise that appointment not be made until they stabilize in their new body. So it sounds like there's support from the two areas that we're requesting be appointed to the JRAC to have a seat. That's really the only thing that has changed, but we don't have a quorum, so we can't make an official vote. And so we can push this to our June meeting. Anything else you want to add?
yeah, for the purpose of clarity, it says Buncombe County Treatment Courts. I think we just need to, so we said it's gonna be a graduate or, we're not putting all of the courts on the JRAC. I think we just need to be more specific in the language.
A representative,
From-
alumni, a graduate of the Buncombe County Treatment Course, and we also specifically said that they would be a recommendation from the treatment court leadership team.
Nomination
From that.
from that leadership team.
Yeah.
So the management team, our quarterly management team, can you just let Julia know so she can get that on our agenda? I think we're meeting in a few weeks.
Okay.
And it's not peer support, you want an alumni?
A graduate.
That was a suggestion at the
Okay.
steering committee, a graduate.
From the adult treatment or vet or all three or just one from any of them?
Judge Thornburg just made that recommendation that any of them,
Yeah.
it's one representative from one of the courts.
So one altogether.
One altogether.
Yeah, one of them, one representative from any of the three courts.
That's it.
I
They
just
said
need
it
to
was someone
state
with
it.
lived experience who has gone through our courses. Alright, so you got something else? Anything else, Josh? Alright, so we'll bring this back in June.
So it'll probably be next quarter, Judge Keppel, if it gets adopted, so not this meeting. But we'll let Julia know.
Alright, so up next, Donald. Donald, this is a result of some conversations we've had as well. We wanted Donald to come and educate us, give us some more information around the work that is happening in the behavioral health space, which ViHealth leads for our county, and that its intersection with the justice system. So I'll turn it over to Donald.
Want me to stand up here and
No, that'll be.
Yeah, we want to see you.
front and center?
Up front.
So I always think it's good to know, I know we've been sitting at this table for many, many years, personally, but how many people actually understand what ViHealth is and what we do? You guys probably heard our name a lot, but probably don't understand the moving parts. She does, sits on our board, she gets to see some of it, but there's really a lot of moving parts to it. And so I don't even have enough time today to really go over the moving parts, but I want to give you a feel for who we are and what we're trying to do in the community, because we've been around a long time. We've as an organizational, not ViHealth, we've changed name a few years. We've been around for over 50 years in our local community. We started out as the area authority. So for Buncombe County, that was the Blue Ridge Area Authority. Anybody remember that? Yeah, I used to work for them back in the day. So I've had a lot of experience. I've come all the way through that. Buncombe County has always been my home base, and so this is my home county as well. And so even though I work across the state, Buncombe County is my home and what I love, and I always want to support this community. So Via Health right now is it's a over $1 billion health plan that we're operating for the state. We manage all of the, I won't say all, we own a portion of the state Medicaid dollars that go to the counties that we support, and I'll go to that next. The federal block grant dollars, so you think about federal substance abuse dollars, federal mental health dollars, those dollars come to us through the state for allocation to our local communities, as well as any dollars allocated by the State General Assembly for state uninsured care. So people that don't have Medicaid, they don't have any insurance at all, how do they get access to that? Those dollars, not a lot of dollars. Let me try to say we don't have enough dollars for that population, but they come to us and we manage those on behalf of the state to try to help as many people as we can with the amount of money that we have. And then we manage, support the counties in managing a limited amount of maintenance of effort dollars. The counties have contributed to the system over the years, all the way back to the old area authority days. Buncombe County, it's roughly about $600,000 that we work with the county on identifying priorities and making sure that those funds are utilized. You can go to the next slide. This is our current catchment area. VIA is currently responsible for 32 counties across North Carolina. If you watch the news or everything, it's always constantly being shaken up. General Assembly is always trying to get us down to a manageable size. If you go all the way back to the original map, to the area authorities, there's over 60 area authorities, and then over the last 20 years, it's gone whittled down until now we're on some final mergers where there's going to be 4 statewide going into July. And so that's roughly where the state wanted to get. So we're hoping there won't be a ton more mergers. There's a lot of work. But currently, those are the counties that we're operating in across North Carolina. Go ahead. And so what do we do? Go ahead. Let's flip to that. So our current, I already talked about our federal, state, and our county dollars that we're managing. Right now, we're focused on specialized, we've always been focused on behavioral health. And so that's all the mental health, substance abuse, and services for individuals with intellectual and developmental disabilities within the system. We manage several waivers on the Medicaid side around that, and so probably don't need to remember those names, but they get complicated on who can qualify for. There's a Medicaid B waiver that we manage, which is an overall Medicaid system. We also operate an innovations waiver, and that's specifically for individuals with intellectual developmental disability. On the waiver, the state allocates so many slots to individuals with that, and so not every individual in your community has a slot for that particular waiver with that. So an individual may need to get the services, but they may have to go on a wait list to get one of those slots. Currently in North Carolina, the average wait time for an individual to get an innovation slot is 10 years. So if you can imagine you have a child that's 7 years old and identified with an intellectual developmental disability, and you're like, hey, I need to get my child on the waiver. They need support. They put them on there. They're an adult by the time that they actually get an access to a slot in North Carolina within that waiver to be managed. So very few kids actually are getting slots unless it's an emergency slot. So we do have some kids that have very high-end needs where they can be granted an emergency slot within the system. So we partner with more than 4,000 healthcare agencies and practitioners. We'll get a breakdown of that in our system. If you go ahead and switch to the next slide, I think I do. Okay, this is a breakdown of our statewide numbers. So right now we currently have close to 2,000 unique contracted providers in our network across the system, which represents close to 13 different sites where people can access services. And so a lot of times people think, hey, you know, what health plan do I want? A lot of times people are looking like, well, how can I get access to services within those health plans? And so we've pretty aggressively worked to make sure that our members have access to as many services by many providers across the system as we can get. And so you'll see a breakdown in the next slide, if you want to roll that to that, of what our current network looks like. And so the first map I showed you was 32 counties of North Carolina, right? And you guys are like, okay, you're responsible for 32 counties. But in reality, we all know that people just don't access services in your county, right? There's plenty of people in Buncombe County that get their services in Hendersonville. Or plenty of people in Hendersonville may get their services in Polk. There's a lot of people in Polk that get their services in Henderson, right? People get their services all over the place. You may need specialty care at Duke Hospital in Durham. Well, that's not one of our counties, but we still want people to get access to those services, right? So we've developed a statewide network of behavioral health providers all the way across the state. So people can access services all across the system. We don't want to have any barriers of a county line being an indicator of whether somebody can access the right services and supports. And so on this map, you see a combination of our behavioral health network as well as our medical network. And that's really a key piece, one to make sure people understand is, as of today, we're managing all this behavioral health services. But on July 1st, the state of North Carolina rolls us into a quote, a tailored plan, which means we're responsible for all the individual's Medicaid allowable services. And so we'll be responsible for all of their medical. They have diabetes or hypertension or they're overweight. All of those responsibilities will be ours to manage. And so when I ask questions about their mental health, my brain's also thinking is, what is those medical health disparities that we should be looking at too, that are drivers of mental health and substance abuse and addiction within there. Looking at whole person care, right? You can't just look at the mental health without looking at the medical issues that are going on with that. States recognizes that, and so that's part of the integration that will be happening in July, where we will become, quote, a tailored plan, and we'll be responsible not only for their medical, we'll be responsible for all their pharmacy benefits, making sure people get their medications, any non-emergency transportation, making sure people can get transportation to their appointments. Over the last 20 years, every survey we've done in our counties around members getting access to care, the number one survey on there, why they couldn't get care, was transportation. Wasn't because they couldn't pay for it, anything else, they couldn't get there. That changes on July 1st for us because now we have access to we can manage the transportation network. Historically, a lot of those networks were managed at the county level by DSSs or through contracts to where they had vans that did certain routes across the county to pick people up and take them to their apartments or to their appointments. It was very limited. On July 1st for us, that changes. Anybody in this room wants to be a Medicaid transportation provider and take their car to pick people up and take them to their appointments every day, just like Uber and Lyft will be in the network. They can not only get access, but people can actually go to your house, take you to your appointment, and then take you back to your house. You don't have to go to a bus stop. You don't have to go to a certain route. You'll be able to get access to your appointment by calling a line, having somebody come up, pick you up, take you to your house, and get you to your appointment. So extremely excited about that because that gives us inroads to helping people get access to services that they never had before in their system. And it's creating a lot more providers and vendors in our system that are raising their hands like, yeah, I'll be a transportation vendor. I think we all probably know people like, yeah, I drive for, DoorDash on the side, after work on the things and make a little extra money. People can do that. The DoorDash drivers now can be Medicaid transportation providers that help people get to their appointments. So pretty exciting, right? The opportunities that are available there. Go ahead. So this again, the breakdown of some of the physical health services, pharmacy network, mental health, substance abuse, IDD, talked about innovations, TBI services, we'll be managing for individuals with TBI, long-term services and support. So we'll be working with people in nursing homes in care and for that level of care, medical care as well. local health departments. Those are all contracts with us now, and health departments across the system, rural health centers, federally qualified health clinics. Those will all be our partners in this conversation. The exciting part about that for us is we used to have behavioral health providers over here, and we used to have medical doctors and other people over here, right? Our goal is, our system is let's get these people mixed up. Let's say if you come in for your medical appointment, you can actually get your mental health needs met with your medical doctor as well. And then really infuse this medical piece with our behavioral health providers, which has always been really focused on them dealing with your thing, but to also start asking the question of, okay, what is, not just what's your depression score, but, what's your A1C, score? Are you managing your diabetes? Are you, what are you doing to do that on the behavioral health side, and making sure those two are linked? And so we'll be doing a lot of work around that and really talking about integrated care and building out our provider network. I think we're going to run through a couple of maps real quick. I'll go through these for time, but this is just what we look like right now with our hospitals and critical access. You'll see we got hospitals all across the state with most of the major health systems. There's a couple of dots missing on this particular map. I noticed Duke Life Point hospitals, we have them under contract, but not showing up on this map. We're trying to finalize one of our last big hospital systems with Atrium Health. They are, if you ever done contracting, they are a challenge to get a contract with, but we're really close there as well. Go ahead and change the slide there. This is what our network with federally qualified health clinics. You see they're all over the place, all over the state, managing that across the system. Next. Skilled nursing centers, we got those under contract and continuing to build. And so our goal is to have the largest and most robust provider network in the state. And so that's what we're doing now. And, some people are like, oh, Blue Cross has got this incredible network. Well, right now our network's rivaling anything Blue Cross has. Our behavioral health network is twice as large as Blue Cross's network. They still got us on the medical side, but we're still working on that. We got some time, and we do expect that our medical network will catch up to theirs as well. Next. Primary care providers, this is key. I will say that at least for Go Live 7/1, starting next Monday, providers in our network get to start our primary care choice period, which means they get to choose who's designated as their primary care provider in our network. We're excited to see, based on contracts we have in place, currently as of today, 91% of all the members that we're currently serving now will get to stay with their current primary care, won't have to change unless they want to, and have no disruptions there. Once we get Atrium under contract, that number goes up over 95%, which means that we're going to be less than 5% of our people will have to look to work with a different PCP than they are today. So I'm excited about that. Next. Trust me, I'm getting to the local stuff real quick here. This is the specialty providers, no big deal, other than just you to see that we got specialty providers all over the place for our providers to get, our members to get access to services. It's our pharmacy network, and so we work with the vendor Navitus, which is a national pharmacy benefit plan manager that has just about every Medicaid pharmacy across the state in their network, and adding some additional ones as we go. And now, Buncombe County. This is sort of drilling down into where we're at in Buncombe County. This is the providers you currently have in Buncombe County. We try to coded these kind of based on areas for you guys, Asheville, Arden, Transylvania, so you can see historically the providers in the county always congregate around the interstate intersections. So it's always looked that way, of course. But you'll see there we roughly have 181 providers currently operating in Buncombe County doing, and this is strictly behavioral health at this point. So this is providers that are just doing mental health, substance abuse, and IDD services. So generally when you hear the conversation, people can't get into services. One, it's usually they don't know how to get the service, or two, some of our providers don't have enough capacity that we need to adjust. Not necessarily we don't have enough providers in the system, usually looks at capacity of the system. Like, we got this service, but we can't find people to expand service capacity. So it becomes conversations around, we need more clinical people in our communities, more psychologists. I plug psychologists. They're very hard to find, and the schools push them out very slowly into our system. And the ones that do come out don't always like doing testing, which is always boggles me. Why would you be a psychologist if you don't like doing testing? But there's very few psychologists around, like Grandis in Buncombe County. He probably does 40% of all the psych testing in the whole area. And when he retires, we're all gonna be up a creek, but we're gonna keep working on that.
You do
Yeah.
need a succession plan.
Yeah. Next slide. So behavioral crisis system, just want to make you in Buncombe County, we got a lot of layers to how we manage behavioral health crisis. First one is behavioral health urgent care. County's always supported that. It's been huge in the county. No law enforcement is aware of that, I hope. At RHA, they are moving and getting close to 24/365. I got some exciting news about that center a little bit later in the presentation that we'll talk about, but that's really our core piece of trying to keep people out of the emergency rooms, right? Like, it's really critical when we have these conversations is that we can divert a lot of people from the jail and from the ED if we utilize that urgent care appropriately. And so we need more utilization of that. If you look at the numbers now, the utilization's nowhere where it should be for a county the size of Buncombe County, right? Like, we should have a lot of people going through those doors on a daily basis. They have, as a diversion rate, when you look at that, we track all of that as a diversion rate. They're diverting 99% of the people that walk into their doors, never go to an ED or don't have to go, into a jail situation. And so a lot of times if they're getting into those situations, it's because we didn't really route them in to wrap them with the right levels of supports. We have 2 walk-in centers in Buncombe County. Most only know of one. I think of the RHA walk-in center that's at 356, that's one. We also have another walk-in center that we have contracted for in West Asheville, over there. Name of the
Family Pres.
Family Pres. I was thinking the shopping center area that they're in. You say,
It's past Burger King.
yeah,
past Lester
it's
Howen.
the one there where you got, I only know the restaurants in there, Neo Burrito and Jersey Mike's and all of those, right? But it's in that little shopping center, but that's both of those are 24/7. They're open access centers, meaning you don't need an appointment. You can just show up and access services. And so if you're working with people, you're like, hey, I'm having a bad day, like, they don't need to call somebody and make an appointment. They can go to either one of those centers and just walk in the door and say, I need help. And we contract with them with additional supplements, so they have additional staffing on board where they can drop what they're doing to actually see those people. And so in those centers, anytime somebody walks in the door contractually, they have 15 minutes to actually screen that individual and determine, is this person emergent, urgent, or routine? And if they're emergent, they have to take them back immediately to see someone and get some clinical help. If they're urgent, they only can sit there for an hour or less before getting help. And if they're a routine, there's like a 2-hour wait time in order to get them in there. And that's somebody, far less urgent. We track all of that to make sure that happens. And when they look like that their volume's getting so high, we go back to them and we put more funding in their contract so they can hire more people. And so we want those systems to be overwhelmed. If they're not overwhelmed, there's no point to keep funding them, right? And so it's really important we utilize those and really encourage those. We have a couple of facility-based crises in Buncombe County, the Kylan Burrell Center, which is for our children, and the Neil Dobbins Center, which is for our adult mental health and detox centers, both in Buncombe County and available to that. Mobile crisis management, another thing, we continue to work on trying to get that more robust, put more people on it, make sure that's out there. Some of you guys may have heard of our Moores teams. Hopefully Stoney's heard of the Moores teams. He's not really giving me a good shake. But we have a specific team called a Moores team in Buncombe County now. It's a 3-person team that attaches to mobile crisis. Its specific job is to work with kids that are in crisis, either in the DSS system or in the school system, wrap them around to try to keep them from, one, becoming a custody of DSS, right? Or trying to keep them wrapped in the community so they don't have to go into some higher levels of care. And they can work with people for up to a week at a time, wrapping them around with care. So we got more teams, it's exciting. We're looking to expand those teams all over the state because we're really getting some good outcomes with them. And then we also have a grant in Buncombe County with the law enforcement co-responder model. Hopefully you guys are familiar with that. It's probably more the sheriff's office, but you should know about it. We're doing some really cool work with the sheriff on co-responders where we're attaching clinical people to responding to those calls. So when they go out on a call, officer don't necessarily always have to make the decision is, hey, I'm gonna book this person, or am I gonna like wrap them with treatment? There's a lot of times that if we can screen and wrap, we don't have to book, right? And so that grant's going on. I know DK's well aware of that one.
Donna, when, I am, that's really exciting. When have we started? Are
So
they in-
Sergeant Freeborn
Okay.
is heading that up, and we have our second meeting Monday for that co-responder program. And they are in process, they said earlier today, of hiring the therapist, and RHA is fully on board, so yes.
Yeah, and so it's really important for us, and we're trying to get ahead of this too, because if you're paying attention to state legislation, the last budget bill, there was clear direction from the General Assembly for the Department of Health and Human Services to explore a prison reentry waiver for North Carolina. And so you may be like, well, what does that mean? Well, it really means creating a specialty plan like I've talked about for people that are coming out of the prison or the detention centers, right? Actually making them more, giving them more access to become Medicaid eligible for that, which then opens up a lot of doors so we can wrap them with services and supports while they're in the centers and coming out of the centers. And so we're really looking for opportunities to start building some of these resources across our communities now. So when that prison reentry waiver comes out, we're going to be more an opportunity to really be able to do some exciting things around that. So that's probably about, another year and a half down the road. But as we all know, that flies by, and the time we work with.
Do y'all have any questions about,
Yeah,
can you
no,
go back
run
to
through
that
it,
slide?
I had a question from like 4 slides ago.
Sorry about that.
So just to be clear, historically, folks with Medicaid, they were like county assigned. And if I went from Buncombe and I ended up in like Forsyth, Guilford, maybe New Hanover, there was issues with payment, right? Like transferring Medicaid from county to county. But where we're going to is a plan where I can be anywhere in the state. And if I'm in network, I can get access and service will be paid for through Via.
Yeah, so maybe, the
Okay.
theory. So right now, the Medicaid county of eligibility still assigns it to the health plan, right?
Mhm,
And so if the Medicaid county of eligibility is Buncombe,
mhm.
right? They're in our health plan, right? Now that Buncombe person can live anywhere in the state. Because that happens right now is they may have Buncombe assigned Medicaid, but they're living in Winston-Salem. Maybe in a group home, maybe in a halfway house, maybe in a treatment center, could be all the way on the coast. As long as they have that Medicaid eligibility from Buncombe County, they're ours and we're gonna deal with them. Now, if they decide when they're in Winston-Salem, I really love Winston-Salem, I'm gonna plant down some roots here, I'm gonna get married and I'm gonna, buy a house in Winston-Salem, at that point, usually the individual switches their Medicaid to Forsyth, and at that point, that person would be switched to Partners Behavioral Health Medicaid, and they would begin managing them there from their county. That makes sense. Now, yes. Any other questions around that?
Any more questions? We have pretty rich, in my opinion, resources with our crisis response here in Buncombe County, thanks to Via Health. And so I want to make sure everybody understands that these resources are available, especially law enforcement. And if you have questions about any of these services or these facilities, we can follow up and make sure that you have additional information as well. So just want to pause and see if there are any questions about the services provided in our behavioral health crisis system.
Yeah, I think too, just pointing out, we want to ensure, like what DK's saying, that our law enforcement really is taking advantage of the C-356 especially. There's been a lot of changes, I know there's a lot of turnover staff, COVID, but that it is a true drop-off center. That is there as an ED diversion. And because of COVID and staffing, they had to scale back from 24/7. They're almost there. They are so close. So I know it's confusing, This night they're open, this night they're not. But they have law enforcement there, who that's been a concern, right? Like law enforcement doesn't want to take someone, drop them off, because then they feel like they're saddled with that person and they have to stay there. But they have law enforcement there, so it's communicating with them to ensure, hey, you know, so you can get back, your officers can get back on the beat, leave that person, head off, and you're not dropping them off at the ED at 12 a.m. to sit there for 24 hours before they've been seen, where they can get peer support services. Sorry, how many beds? How many beds do you have?
In the BHUC?
Well, in the drop-off center. that's the
Well, so
alternative.
I'm by it, but yeah, so, the RHA, yeah, they have, and Donald, they have a downstairs, and they have a peer support living room, where peer supports can go, and then I think 8 beds. But go
Yeah,
ahead.
yeah, so they have a couple of things when you drop somebody off, right? Like when they evaluate them, not all of them necessarily need to go to those beds. If somebody's dropped off, they may just need to see the psychiatrist and get a prescription renewed. We see a lot of crisis where, you know, I haven't had my meds in 3 days and it becomes a crisis and now they're hallucinating or they're having, you know, issues and they need to go back and see the doctor. They don't need to necessarily sit in a chair for a couple of days. And so those people are just going to see their doctor. Then they're wrapping them around with mobile crisis and other supports. They're taking them to the pharmacy to get their meds and they're getting their meds started and then they're going back home with them and making sure that they're stable at home. They're dealing with a lot of crises that way. The ones that need a longer stabilization can move into those urgent care beds. Those are 23-hour chairs. There's 8 of those in there where they can stay for up to 23 hours. If they need a longer stay, the Neil Dobbins Center is right there on premises too, and they can stay in the Neil Dobbins Centers for up to 2 to 3 weeks, depending on what their needs are, right? Like if they're on some serious substances and they need to detox and they're going to be there for a couple of weeks and they can move them into those longer term beds in there. So they have all of those options available to them at that center, whether it's a community-based approach, wrapping them in their own home and in their community, or 23-hour chairs or those longer term.
Do you have a estimate of how many Buncombe County residents will move into the Taylor plan on July 1st?
I do. I did not pull that for that. I can send that to you. I'm not sure how many are in there. Do you remember seeing that?
I don't want to say a wrong number.
Yeah, I know. I have a grid of every county and how many there are, but I can't picture in my head what Buncombe's was. And I'm sure that number's fluctuating with the Medicaid expansion too. So, and we're really seeing some good numbers with the Medicaid expansion pieces. The Medicaid expansion is a deal changer for substance abuse. Historically, for our substance abuse services, 80 to 90%, depending on which program you went into, people accessing that were completely uninsured. Didn't have any money at all to pay for services. And because of that, you only could build as many programs as the state gave us money to support uninsured people. Now with that Medicaid population goes up, it's really a game changer on us being able to expand access to substance abuse services because Medicaid is a much better reimbursement payer than state uninsured dollars. It's not even, the number of the populations are almost exactly the same. There's as many people that are uninsured that there are Medicaid that need the services, but the amount of money is like a penny for every dollar difference when you really look at how much money is in the system to support them with their work. Any other questions on crisis? Okay, couple things around juvenile justice. I know we don't have them here today, but we've been working with juvenile justice for a long time. With that, a couple of things we do for them, just so you know, is we provide single point of assessment. So any juvenile that's coming into their system, we make sure that they're being evaluated and assessed with a really trauma-informed evaluation and assessment, because those families generally historically have not been great at going and getting those assessments when you're like, hey, here's an appointment for next Tuesday at 2 to get your assessment. We changed that whole system around, and now the family shows up at juvenile justice and the person doing the assessment is right there in the building. They do that assessment for them. They don't give them a chance to get away. They do that evaluation. It's trauma-informed, and the assessment's designed for our court systems. And so it works really well for the juvenile justice system. We call that our single point of assessments because families only have to go to one point to get those services. And then we've also developed a full continuum of care with juvenile justice. So if you looked at that across the state, we've really done an incredible job of keeping juveniles out of detention centers in Western North Carolina particularly, through wrapping them with other services and supports. And so part of that conversation for us is like, hey, if we can do that in the juvenile system, we can do that with the adult system too. We just got to build these services and supports at the right points to help those individuals. We also work with the DJJ connection. And so I'll say this is where, because we got to get there, we're with law enforcement too. We meet with DJJ like all the time. All of the DJJ court chiefs I meet with personally, we talk about like, well, what are the barriers they're having? What are the challenges they're having across their system? And we work on trying to address those across the system. We also have a JGBH partnership with all of our chiefs. And so all of the juvenile court chiefs from our 32 counties meet with us quarterly as part of a partnership, talking about how do we work together to really improve that care for those juveniles across the system. Really great. We get a small pot of money for supporting that partnership. If you go to the next slide, you can see some programs. Well, we'll get to that. This is again just JJTC. Again, we have staff. All of our care managers are at the juvenile justice case staffings. And so every case coming in juvenile justice, our care management team is at the table and staffing those cases with them. And then we have specific statement. I know I'm running out of time, so I'm gonna have to go quicker. Go ahead and flip through. Again, these are some things that Buncombe County funds with their JJBH funds. We have Camp Greer, where we have 30 youth and 10 staff that's been supporting that. Asheville Outdoor Adventure, where we're funding some programs for juvenile justice use. And then we've also funded 50 wellness boxes for kids in their system on the juvenile justice side. The detention center, familiar with that, we fund a position at the detention center through RHA doing jail diversion. It's one of the few, believe it, all the state dollars they give us. The state gives us a whopping $60,000 a year for jail diversion across our 32 counties. Congratulations, Buncombe County gets all 60,000 of that money. And so we put all that into one position that's at the Buncombe County Jail to help with those diversion efforts. Next. We also support crisis intervention teams. So hopefully our officers know about that. The CIT trainings, those come from our teams. We train the officers and then hopefully accessing those services. We're always open to supports on how to make those trainings better and supports, but we're training not only police officers, but we've had magistrates go through CIT. We've had 911 operators go through CIT, detention officers go through CIT, community paramedics, you name it, we're open to making that training available to them. And then we also support the Buncombe County Resource Center and all of these specialty courts that you mentioned before. We have case managers at all of those courts that are helping connect people, the services across our system. So right now we got, I'm gonna blow this number, but I think we got over 800 care managers that are running across all of our counties that are helping people access and connect to the right services and supports. So a lot of work being done there. Virtual crisis response, that's the new program. I know you want to say something about that? Angie, I know we've been doing a lot of work with the county on trying to get that off the ground.
Yeah, just real quick. So we started this with RHA and over at the courthouse because Major Everhart was saying that, we've got folks that come in here, I don't know how many thousands a day, and folks show up in crisis, and sometimes we'll call mobile crisis, and they could be an hour or two away. Unfortunately, we want them to get there quicker, but there are other crises. So there's some iPads that are managed. Josh right now is over that program to ensure that's happening. But basically the premise of that is someone presents and they look a little out of sorts, so to speak, and then it sort of goes through the team's channel internally to where it needs to go. Someone from Josh's team shows up with a iPad and they're able to actually talk with the mobile crisis responder. And while they're talking with that responder, then they immediately send someone, so there's not that lapse and they're hanging out in the courthouse. They're back into a safe, secure room. So also right now there's a meeting going on over here at the FJC Josh had talked to his folks there about that with Helpmate and Our Voice, and they said, wow, that sounds pretty cool. So we have someone from VIA over there right now with RHA and those folks to look at implementing the same program over there at the FJC.
Yeah, and if you're familiar with the Charleston model, familiar with that, but Charleston has a model where basically they have virtual clinicians in their patrol cars. And so if somebody needs to be assessed, they just set somebody in the passenger seat of their patrol car and they turn their computer monitor around and boom, they're in face-to-face with a person that can evaluate them, screen them, make sure they're not having issues, and then give the officer some information on, hey, it sounds like this person is having some delusional thoughts. You may want to send them over to the crisis center and see what we can do for them. We have some similar models in some of our counties. Haywood County and Avery County both have iPads in their trunks with their patrol officers, and they pull them out, and with those iPads, they can pull up a clinician and say, hey, I got a therapist here. You might, but I got someone that can help you here, and they can bring up a clinician right on the iPad and provide consultation to the officer, as well as do a visual screening of that person and say, hey, it looks like this is going on with this person. This is something you might want to consider in supporting. So some things to consider. Good. And the Buncombe Specialty Courts, I mentioned that. I won't go into any more detail. Keep on going. Diversion programs, I talked about those. Behavioral urgent care, I highlighted that, just wanted to say that. If you saw the news, the press release finally came out on Monday. Excited to do that. That the state, as you know, through their budget, they allocated over $800 million to improve behavioral health and crisis services across the state. They've set aside $80 million over the next 2 years, just particularly for crisis services. VIA's been trying to get some of that money in order to support that. Glad to say that the Buncombe Behavioral Urgent Care has been funded. I can't say so much because the department will not let me say more than what they're willing to say until they take credit for it. But they are funding the urgent care, which will get it to 365, and as well as be able to continue that when the county's ARPA dollars are no longer needed. So that's really exciting for that. We're also excited, I'll just put a plug in, we put in 7 requests for that. All 7 of our requests were funded by the state. They funded 9 urgent cares across the state with the money. 7 of them was ours. And so we're really excited about that we'll have at least 7 functional. And for close to here, that's another one in Haywood County. So it's for there, another one in Caldwell County, Alamance County, Rockingham County, Vance County, and I'm probably missing one. And then I highlighted the co-responder one on there just because I wanted to make sure you see that grant. And then last but not least, make you aware, we're also really connected in the system around forensic evaluations that are happening in your detention centers. Those all come through us and are sent for a thing, as well as the multidisciplinary evaluations. And so if you have someone that is competent to proceed, all of those evaluations come through VIA, and then we work with our network to make sure that those happen. And I think I made it through and I'm not too far over my time. So,
Yeah.
any questions?
Any additional questions? I have a question. So your case managers, do you have any case managers connected to the public housing communities?
Well, I say that loosely. So we have a whole housing team, let me say that. And so I didn't get into this, but we have a whole department in our organization where we call transition to community living. And that department is responsible for nothing else but helping people move in and stay in the community. The state was under a federal Department of Justice settlement around housing people with mental health issues in family care homes across the state. Officers probably know that because they probably respond to family care homes all the time with issues, right? State got in trouble with that. DOJ sued the state. The state had to respond. They came out with a settlement agreement. Part of that kicked off that transition to community living. And so there's money in that settlement to help, one, pay for housing vouchers for people, which pays for that. It also pays for a lot of wraparound services and part of that team. And so we have a whole team that does nothing but work with finding housing for people and doing connecting with supported employment. And so when we talk about all of those pieces, those are two critical cornerstones of helping someone recover. Like, it's not really, can't really help somebody with a substance abuse or a mental health issue. You're not really actually talking about them. Do you have a safe place to live? And do you have a place to belong and work, right? Like, work's a cornerstone of recovery for us. And so we have a team that works with our providers on expanding support of employment opportunities and for housing. And so we do work with all of the housing authorities on housing vouchers. We probably have the most comprehensive network of landlords anywhere in Western North Carolina. If there's a landlord in Western North Carolina that's willing to accept a housing voucher, we know who they are and we know their name. Because as soon as that unit comes online, we want to know about it before the community knows about it, right? Because those things go really quick, right? And so as soon as those come online, we're looking to, can we put somebody with a disability in those units, get a housing voucher? They like the housing vouchers because that's guaranteed money. They don't have to worry about somebody not paying the rent either, right? Don't have to worry about somebody writing the check every month because that housing voucher and that money that we support helps make sure that they have, a regular flow of income for that landlord. So, trying to answer the question.
All right, well, thank you. Lots of information. Remember that Donald is your fellow JRAC member. If you have, or Angie can help you if you have any additional questions about any of the work that's happening. Thank you. Yes, thank you very much. All right, so now we have announcements and departmental updates. Anybody have anything for the good of the group to share?
I'm not, well, I don't know if we talked about porch light at the last meeting. I'll just announce it. The Family Justice Center in partnership with Help Made Our Voice announced a pilot project where survivors can access services at the libraries currently. You can see a little, what do we call it? Turn your light on, porch light. It's a sticker basically saying you can come here to use the phone if you need help calling for services for intimate partner violence, sexual assault. The beauty in that also is staff has been trained to help support people in crisis around sexual assault and intimate partner violence. It's a pilot project, but the goal is to expand to other businesses and other places. So if you guys have any connections with grocery stores, gas stations, any type of business, restaurants, we would want to be exploring there. Again, the goal is to really raise awareness so individuals can help support people if they see people in crisis around intimate partner violence and sexual assault, but also being able to have a phone or access to a phone so people can call when they want to seek services. So be on the lookout for the porch light. And it's a nice little porch light that they did. The logo is like teal and lavender. We'll send it out in our follow-up so you guys can be familiar with it when you see it.
All right. Anything else? More announcements? All right. Well, then we've come to public comment. Do we have anybody online who wants to provide public comment? I think I see any new faces in here. All right. Well, then I'll entertain a motion to adjourn. I don't say it too fast. I saw her lips. So moved. Second? All right. Well, y'all have